appreciate your cooperation and really want to express our gratitude to folks from the Department of Medicaid Services for being here today and the Cabinet for Health and Family Services. I'm going to start off by introducing the Honorable Secretary Vicki Glisson, who is the Secretary for the Cabinet of Health and Family Services. Vicki was appointed the Secretary by Governor Bevin back on December 9th of 2015. She's an attorney with extensive experience in healthcare law and finance with special expertise in the privacy, security, and technology transfer of health information. Secretary Glisson worked closely with the University of Louisville Foundation on planning development, building partnerships, and securing tax increment finance for Nucleus, which is Kentucky's Innovation Center at the University of Louisville. In 2008, she was named President and CEO of Nucleus and oversaw its mission on fostering the growth of innovative research and technology companies in the Louisville area. Secretary Glisson has held a number of government appointments, including serving as a member of the National Institutes of Health's Advisory Council for the Human Genome Project and the Advisory Council of the National Institute of Diabetes, Digestive, and Kidney Disease as part of the National Institutes of Health. She has also served on the board of directors of the UL and Kentucky One Health Cardiovascular Innovation Institute. She's a native of Spencer County and a graduate of Georgetown College and the University of Kentucky College of Law. She lives here in Louisville with her husband. Please join me in giving a warm welcome to Secretary Vicki Glisson.
Good morning, everyone. It's so nice to be able to be here today. I'm going to kick us off for a few moments. I'm going to have my partners to come up here with me, if that's okay. We'll have some folks come over here, over to the side, maybe. Got a little close back here in the back, so we're just going to kind of fan around. We're really excited to be able to be here today because the presentation that you're going to hear is really based on a very exciting and innovative initiative that was begun at the Cabinet for Health and Family Services, and particularly our Department for Medicaid Services. I don't have to tell you that the theme of the day is quality. We hear about quality all the time, and I know that each of you in managing healthcare organizations are focused on quality every day. And it's certainly a resounding theme with our payers, and whether these are private insurers, whether it's Medicare, Medicaid, individual patients, everyone is demanding, it seems this day, or these days, quality. And anything short of both quality and for providers efficient care has now become unacceptable, it seems. So one of the things that I was concerned about when I became the Secretary of the Cabinet is that in our little piece around Medicaid, and knowing that the problem that we have is that everyone, all these different organizations, define quality differently. And it's very frustrating for providers. And so I really have a soft spot in my heart, of course, for providers. And so very concerned about how providers can continue to be able to really effectively keep their practices going and deal with all of the different pressures they have around different metrics around quality. And so, as you know, I mean, the NCQA has quality standards. They've got the HEDIS standards. We have, in 2015, Medicare replaced the sustainable growth rate with MACRA. And then Medicaid has its own quality standards, and that's just a few. Unfortunately, as I said, there has been a misalignment. There's actually been an imperfect alignment among the measures as defined by all of these different payors and all of these different systems. This has resulted in really, I think, making your job very complex because you have a myriad of competing quality measures and that's created a huge administrative burden on the healthcare system and particularly our providers. So not only has this been a burden placed on an already strained system, but there have been very few meaningful improvements in quality that have been able to be truly quantified through all of this effort. So our cabinet then wanted to do all it can to assist our state's providers to be able to meet these quality measurement requirements, and particularly those that are now being required by MACRA. We feel that we're really kind of facing a cliff here. And I know that our Department for Medicaid Services and our partners here are very concerned about that cliff because it's now here and it's upon us. So we have spent a great deal of time in the last 1.5 to 2 years since we've been in Frankfurt trying to assist to find ways that we can try to make sure that our providers, we lessen the probability that they may be facing a penalty as the MACRA measurements are coming into being. So that's what we're announcing here today. It's a crosswalk that we've been able to effectuate between the Medicaid quality measures and those that are required by CMS and MACRA. We can at least start with our piece, how we crosswalk Medicaid, and what you're going to hear today from our folks at our Medicaid office is how they've spent the time and the effort to crosswalk those Medicaid measures with those that are required by CMS. The most important thing we want to make sure that doesn't happen this year, or when it actually goes into effect in 2019, is that any of our providers are faced with a penalty. We want to help you understand how that you can at least stay status quo and not be faced with a penalty. That is what our goal is, and why we've all come together as a group to align. So we have had several partners, and these are many of the partners that are working with us, that they've worked to help us identify this measure set. I think it's going to be called today a crosswalk. It's a crosswalk that's going to help you as managing practices around the state, how to satisfy those quality measurements across all of these organizations. But at least at this point, how you're going to be, this crosswalk will help you get between Medicaid and Medicare. What you see because of this alignment is that we're starting with Medicaid and Medicare, but I want you to know that we're working together to then broaden this across the whole spectrum of all providers. And so I want you to know that that effort's going on. I think we appreciate the fact that folks wanted to come up here and be with us to stand up to show that we've now got this very public-private partnership that we're starting with Medicaid and Medicare, but it's going to be much broader across all payors. We have worked, as I said, with numerous partners. I would like to just take a moment to thank some of those partners. I want to say thank you to QSource. QSource came early on when we reached out from Medicaid to say, is there a way we can try to work with and help our providers? And QSource said yes, and so it's been a pleasure to work with Margie Bantz. I also want to thank Lindy Lady, and I want to thank Pat Paget from the Kentucky Medical Association. We could not have gotten this done without their help and their assistance. We also worked with David Bolt of the Kentucky Primary Care Association. Thank you, David. And then we have our largest employers in the state. That's very important, and we have they're involved, and we have Randa Deaton, we have Teresa Coots, we have Diana Hahn, and Stephanie Klauser from the Kentuckiana Health Collaborative. This is, as I said, a collaborative of our state's largest employers. So you can see that we've now begun to get a real core group of folks that are saying, let's all identify what is quality, what measures are going to be used, and we're all going to be reporting on that same quality data. It's only if we can do that we can really start comparing truly apples to apples or oranges to oranges. We know that we all have kind of agreed on what that quality data is. We remove some of that administrative burden from the providers, and then we're all working together, because then we'll truly be able to quantify whether we're actually moving the needle, whether we're actually improving quality and doing it cost effectively. I thought maybe it might be helpful if I just gave some of the quotes that the organizations that are represented here today have given us, and so I would like to just run through some of those. From the Kentucky Medical Association, again, thank you, Pat, and Lindy. Every insurer and government program defines quality in their own way. They require different information to be submitted by physicians, which increases the administrative burdens and cost, while confusing patients about just how the healthcare system defines quality. The Kentucky Medical Association is happy to assist the Cabinet in reducing these administrative burdens and helping to create a better system of quality measurement. And then from the Kentuckiana Health Collaborative, our large employer groups here in the state. Measurement alignment is a priority that is best achieved by bringing together key business, government, and healthcare sectors. The more we can get these public and private organizations to align around the same measures, the better we can focus on improvement towards shared goals and shared areas. Kentucky Health Collaborative is committed to developing this common measurement and set through a deliberate process where key experts will be able to collaboratively agree on Kentucky's priority measures. And then from the Kentucky Primary Care Association, the partnership between the Department of Medicaid Services and the provider groups across the state is a positive step in improving the health of Medicaid members. The Kentucky Primary Care Association member clinics are pleased with the leadership at the Department of Medicaid Services for providing a Kentucky-driven direction on healthcare quality measurements. And then from GE Appliances, one of those members of the collaborative. It is impossible to drive systemic improvements in the quality of healthcare without payer, purchaser, and provider alignment around a common measurement set. The Louisville-based GE Appliances is committed to public-private partnerships to enhance efficiencies for all healthcare stakeholders with the end goal of driving improvements in the health of our employees, their families, and our entire community. And then from Humana, Kentucky's largest health insurer, aligning healthcare measurement. Isn't it nice to know that the insurers we all might be able to have some alignment around the same measurements here? Aligning healthcare measurement has been a top priority for Humana for several years, and it has been a natural progression for us to join other Kentucky health plans, employers, and providers to develop this common measurement set. We're committed to a broad community measurement system that produces meaningful improvements to health outcomes, and it reduces the administrative burden on our providers. And then lastly, from Ford Motor Company, we value being a part of this public-private partnership to get a shared understanding of the healthcare measurement priorities that matter most to our community. And this is a quote that Randa helped provide for Ford. And so Ford says, by joining our public partners, we can now collectively make systemic changes necessary to improve the health of our employees and our communities. So we must strive, obviously, to improve quality. We must make sure that we're providing cost-effective health care. We're only going to know that if we all come together in a partnership to align ourselves and work with our providers to decide what quality measures are truly important, try to remove some of that administrative burden, particularly that redundancy that providers have had to endure. Work together. Let's get common measurements, and then we'll truly be able to quantify whether we're moving the needle and we're improving healthcare and we're doing it more cost effectively. So with that, I also want to take a moment and just say I want to recognize Commissioner Miller. He's somewhere. Oh, there he is. I'm sure many of you know Commissioner Miller. Commissioner Miller is our Commissioner for Medicaid Services, Steve Miller. And I want to turn it over now to Steve because Steve has done a great job. It's through Steve's leadership that we've been able to get to this point today. This is a first step. This is the first step in a much broader effort, as you can see. And in fact, what I want you to know is that we're actually leading the nation in this effort. There is no place in the nation that is working, that has now been able to get this kind of alignment around quality measures. So what we're doing here is cutting edge. It's innovative, but it is the right thing, particularly the right thing to do for our providers. So we need to get ourselves together and get aligned. But it's very exciting to be a part of something that is really leading a national cutting-edge effort and initiative. And it's wonderful to be up here with these folks that are our partners. And it's Steve's team that has led that effort. And I must say that the person I leaned on very early on, he's going to talk about his team. He's got a fabulous team at Medicaid. The person that I said was like a dog on a bone was Judy Baker. And I said to Judy, I think we can figure this out. Steve said, I think we can figure this out. And Judy ran with it, but only because she had the right folks also backing her up. And so I really want to do a quick shout out to Judy, but to also thank Steve for his leadership. And I'm going to turn it over to Steve. Thank you.
Good morning. I want to echo some of the things that Secretary Glisson has already said. This is clearly the beginning. It is a process. This is not ending here today, as was pointed out. We want to move this through all insurers as well to make things as simple That's tough today in the healthcare environment, but at least as consistent as possible. Like many of you, I've spent most of my time on the provider side of healthcare. The ability to be able to look at something and put something in place today that reduces the administrative burden, adds to the consistency of the data, that makes it more usable, it's a win-win situation for all of us. But let's also not lose sight of what the product is supposed to become the end of the day, and that is how we use that data to be able to measure and determine better outcomes for the patients, for the people, the citizens of Kentucky that we serve. That is the goal. We want to enhance the outcomes of those people who we serve. It is very gratifying to be able to stand here before you and say, I believe what we're in the process of doing will achieve that. As has already been pointed out, it has taken many organizations to get to where we are today. Yes, Medicaid has taken the lead on it, but I've learned long ago, sometimes in leadership you need to lead, and other times you just get out of the way. And this is one of those cases where I was able to get out of the way because the people who I had underneath me who had there to support me to get things done. At this time, I would like to introduce two key people that were involved with that from my shop. Now, we would not be here today without their hard work, without their initiative. They live and breed, quality measurements every day. And at this time, I'd like to introduce those two key people, Judy Baker and Mary Dale Coleman. They will be your presenters for the day. Sit back, learn, be a part of this process. Thank you.
I want to say thank you for all of you coming today and helping us, and especially to all of our partners that have came in and participated with us and showed their support today. One thing that we do want to let you know is it is being live streamed and it's being recorded for our websites. And hopefully we're working with Lindy Lady and other groups to try to offer continuing education credits and CMEs for physicians and others that could not attend today. When they go on our website and take those, we're going to hopefully have those worked out to offer those. A little bit about the project. I really want to thank Secretary Glisson and Commissioner Miller for allowing us to actually just take this and run with it and to build the partnerships we have. When I first started Medicaid, which was just 4 short years ago, everything we were doing was in silos. It seemed like we weren't working with our sister agencies. We hadn't developed some of the collaborative efforts that we have, and they have been a great administrative team to where they've let us just go out into the community and build not only with our sister agencies, but also with private partners. And KMA has been and KPCA have been both right there the entire time that we've been working with quality. And then again with the Kentuckiana Healthcare Collaborative, when they found out we were working on this, they were working on the private side, and we were able to join together to make this happen. Today's presentation, we're going to give you just a short little overview of the MACRA and the MIPS section, which is mostly what our providers will be falling under. And then we're going to tell you how they kind of get the quality measures, get into the payment system. We're not going to try to explain all the Medicaid math and the Medicare math to you, but there will be resources at the end of the presentation that you can look at. And to get some more help, we actually have Sue from QSource, who, if we have questions that are more in-depth than what I can answer, she has graciously said she will try to answer them for you. And then we're going to explain to you about our CROSSWALK and how, if your physicians choose to use these measures on the CROSSWALK, they can fulfill their 6 quality measures with their high priority and cross-cutting efforts that they're required to do for MIPS. And I think this year they only have to report 1, but if they do the 6 with the priority, then they can actually be available to get some bonuses. And right now I'm going to turn it over to Mary Dale, who's going to give you the overview.
Making sure y'all can hear me. Any problems hearing me? Okay. I am going to be speaking about MIPS, and I just want y'all to know that this is a little difficult to understand, but I'm going to try and make it as easy as possible. But there are resources to go into to find more information about it. MIPS. Okay. Most of you all are aware of MIPS, but we want to give you just a very, very, very short review of it to understand a little bit more about why it's important to have these quality measures and how to get those quality measures. MIPS is one of two payment tracks in MACRA Quality Payment Program. MIPS affects payments in 2019, but it's going to be based on the 2017 data that you are collecting right now. It replaces CMS's PQRS, electronic health records, meaningful use, and your VBM measure programs. MIPS has 4 categories in the reporting. Again, that is quality, which is going to be replacing your PQRS, cost, which is replacing your VBM, a new category for improvement activities, and advancing care information that's going to be replacing your meaningful use that you've been doing in the past. I want to go over just some of the parts of the quality. Most detailed information is included in reporting measures and can be scored by visiting the Quality Payment Program website, which is included at the reference of this. There are 6 domains: patient safety, person and caregiver center experiences and outcomes, communication and care coordination, effective clinical care, communication and population health, and efficiency and cost reduction. VPM, as we know, Medicare will be using this as a cost instead of the VBM. Medicare uses claims to score the cost based on total spending per Medicare patient or total spending per patient per episode-based measures. That's a mouthful. Improvement activities. This is the part where we actually get to kind of brag about what you all are doing to improve the outcomes of your patients. NCQA recognizes the PCMH, and clinicians receive full credit and are not required for this category to report this category for Medicare. Advancing care information. This is what meaningful use was, or what we still have. And a lot of this you all are already doing. You're doing electronic prescribing. You have a patient online access to health records. You have an electronic system engaging your patients in their health care. You're sharing the data, and you're reporting to public health and clinicians such as the Registry for Immunizations. There are also bonus points that are possible by using the electronic system to report measures right directly to Medicare. Now we're going to get to a little bit about what I call the Medicare math. Please forgive me, this can be a little bit difficult and hard to understand, but again, there are resources that will go over this. MIPS breaks the scoring for the 2017 measurement year paid out in 2019 into the following percentages. Quality is 60%. Cost is 0%. Improvement activities is 15%. And advancing care information is 25%. Quality is the biggest portion of this scoring. Providers can receive 3 to 10 points for each quality measure reported based on comparison to benchmarks. CMS will award 2 bonus points for each outcome comparison and experiences and measures, and 1 bonus point for each high priority measure that is reported beyond 1 high priority measure that is already required for reporting. It's going above and beyond. Total quality score equals the points earned for the 6 quality measures plus any bonus points earned divided by the maximum number of points. The maximum number of points is equal to the number of required measures multiplied by 10. Are we having fun yet? Again, this is a little bit hard to understand, but there are plenty of resources that will... Is that better? Okay. Like I said, this is Medicare math to the max. There are lots more videos. There's lots of information at the end of the presentation that will help you with this, and we have a bunch of resources here with us today that kind of go over this too. Cost will not be required for the 2017 measurement year. When CMS does start requiring the category, it will be scored using claims data with extra reporting required. The cost will then be equal to the points assigned for the scored measures divided by the number of scored measures multiplied by 10. Again, this is weighted 0 for this transition year.
And one thing that's interesting to know about that portion is that's the one part of MACRA that the physicians don't have to really do anything with, because it will be gleaned from their claims data reported to CMS. If we could just do all of the measures that way.
Right. Improvement activities is again weighted at 15%, and most providers are required to report 4 medium activities or 2 high-weighted activities or a combination thereof. Alternative activities are weighed for groups with fewer than 15 providers, and these providers are required to report 2 measures or 2 activities. Patient-centered medical homes and specialty practices automatically receive full credit for this category. MIPS providers must earn 40 points in the improvement activity category to receive full credit in 2017. Score is calculated by dividing the total number of scored points by 40 and then multiplying by 100. This score again counts for 15% of the total MIPS score. This is not easy to understand, and I get it. But I want you to understand that there's lots of resources, and we're out there to help you all with this. The next one is the advancing care information. This is 25% of your overall MIPS score. Providers can earn up to 155%, which is capped at 100, for reporting on measures that are relevant to their practice. This score is a combined total of the equal required base score of 50%, the performance score, which is up to 90%, and the bonus score, which can be up to 15%. To get a detailed, more explanation of this, there are some resources at the end of this presentation to kind of help you out. This is what we really want you to kind of look at. This kind of breaks it down visually, and if you're one of those people who likes to read, this will do that too. But we're looking at your quality plus your cost plus your improvement activities, and then what you're doing to advance care performance. And now we are finished with the Medicare math. Thank you. The next part, which is probably what most of you are more interested in, is how this scoring is going to affect you.
And this is where Secretary Glisson was talking about that if you don't report from ACRA, you're going to end up getting penalized 4%. We do not want our state Medicaid providers to be penalized. And if you report nothing and stick your head in the sand, that's exactly what you're going to do. You're going to lose 4% off of every Medicare claim that you submit. If you report one measure, that can actually keep you from getting dinged. If you report a full year and all of the categories you need to, you can actually earn incentive programs. And we actually would love to see all of our Medicaid providers that are eligible for MIPS get those incentives instead of getting penalized.
Okay, our focus at Kentucky Medicaid is on the quality category. We have collaborated with QSource KMA to develop a crosswalk of these quality measures. The crosswalk includes 23 HEDIS measures that meet the reporting standards for MIPS and are currently collected by Medicaid. The crosswalk shows other quality programs that the that the measures belong to, and that also shows the measure identification. There's 2 different ID numbers. There's a description, there's a priority status levels, and also the domains.
And we have actually placed copies of the crosswalk on your tables if you're interested in seeing a more tangible version of it. We are also trying to work with some printers to come up with a laminated type that will be able to be sent out to all of our Medicaid providers in order for them to have it in their administrative offices. We're going to be placing this on our website in an Excel format to where if your physician's office decides that they want to use this crosswalk measure, will actually be able to pull it off of our website, pick which 6 they're doing, and customize that Excel sheet to do their own individual crosswalk for their practice.
As you can see on the screen, everything is there except for the description. It was just too hard to get that description added on the screen, but it is on the handout that you have. You can see where it looks at the MIPS and the HEDIS measure title. It also has the NQF number. It also has the PQRS number, so if you use one or the other, it's there. It has the measure type. It also tells you if it's a high priority. It also tells you the MIPS reporting method. It lets you know if it's a cross-cutting measure. It lets you know if it meets the ACO measure, the Meaningful Use 2 measure, and it also lets you know about the CMS core measures, whether it be an adult, child, or child, and adult measure. This is my favorite part. I'm going to show you one of the measures and how this one measure meets everything across the board. This is a comprehensive diabetic hemoglobin A1C, poor control that is greater than 9%. As you can see, you have your NQF number, you have your PQRS number, you have your measurement type as an intermediate outcome, you know it's a high priority, you have several different ways of MIPS reporting it, you have it as a cross-cutting measure, it meets your ACO measure, it meets your meaningful use measure, and again, it meets your CMS core measure of adults.
And one thing I would like to say about the reporting measure, the type of ways you can report your measures, and I hope if I misspeak that QSource will correct me, that this starting first year, CMS said, okay, you've got to pick one way to report everything, and that's where you're going to have to stick with it. They heard the physicians that didn't really think that would be the best way to practice, so I think next year they are opening it up to where you don't have to just say, I'm just going to report with my EHR, I'm just going to report with a registry, or through claims. You can report different measures through different ways next year.
I pulled this one out too. This is the one controlling high blood pressure. Again, this one has your NQF number as 0018, your PQRS number as 236. It is an intermediate outcome. It is another high priority. Multiple different ways there for MIPS reporting methods. It is a cross-cutting measure. It's an ACO measure. It's a meaningful use to measure. And again, it's a CMS core measure for the adult measures. Now I want to show you one that doesn't quite meet all of it, but it does give you a little bit more insight as to what you can get credit for. And that's the chlamydia screening for women. Again, it's your NQF 0033, your PQRS number of 310. It's a measure type of process. It is not a high priority. You use electronic health records to get the reporting method. It's not a cross-cutting measure, but it does meet your ACO measure, it meets your meaningful use measure, and your CMS core measure for adult and child.
One thing that we wanted this crosswalk to do is show you that all of these measures on our crosswalk are HEDIS measures. The reason we pick these is Medicaid requires all of our managed care organizations to be NCQA accredited. Part of that accreditation is they have to report on HEDIS measures. Over 90% of the country, healthcare systems report HEDIS, something we cannot get away from. It's very standardized. It has very detailed methodologies for creating these measures, and they are all NQF endorsed. So we started with that because that's what we collected. And we crosswalked, okay, how many of these are on the macro with the MIPS? And then Margie and QSource informed us, well, the ACOs have a required measure set that they have to report. So we put that on there. How many of those actually fit in that category too? We want the physicians to be able to look at these, and since quality, which is the 60%, requires that you, to get full credit, report 6 measures, and that one of them has to be an outcome measure. And if you can't have an outcome measure in your practice, it's not available, then it has to be high priority in order for you to get the maximum points that you can give. This way, using and looking at the HEDIS measures, you can see which ones of those fit into your practice. And okay, if I do diabetes, I've not only got my outcome, I've got my high priority. Where you might not want to do the chlamydia screening because it doesn't fit that high priority. And it's a process measure, not an outcome measure. So by using that crosswalk, your physicians can be able to make their life a lot simpler choosing the right measures that hit all the categories. Also, meaningful use is still being practiced in Kentucky. We still have our program running for that, even though CMS has not continued that with Medicare. And you can get points for attesting to Kentucky Medicaid meaningful use. So if you're participating in that meaningful use, use that to help get your meaningful use points in the advancing care information portion of MIPS.
And now I'm going to switch this over and let Judy talk about some of the other efforts and projects that we have going on.
One of the things we wanted to express is what Commissioner Miller said. This is exactly just a starting point. We're just scratching the surface, and they are allowing us to partner with some great people. We have started with an IAP group from CMS. And what they do is they help develop programs with states for Medicaid to help them be able to accomplish more by providing them with expert opinions and expert advice to do these things. Right now, currently, in Medicaid, we do an incentive program for our Medicaid managed care organizations that's completely based on all HEDIS measures and their performance. So what that trickles down to is they incentivize the providers based on those measures, which are over 90-some measures, and each MCO picks a different one to put their money out there. The IAP group is helping us. This will be our last year with that incentive program for the MCOs. They are helping us develop an incentive program that will more mirror MACRA and the MIPS, and that we're going to be using the measures based on the crosswalks that we develop to narrow that down from reporting on 90-some different measures to which 6 or 7 measures really are important for Kentucky's population of Medicaid members. Focus on those. We incentivize the MCOs. They will then force that direction and that focus in on the providers, and it'll all be the same ones. Not, I'm picking 5 from this side, I want to do 5 from over here. Everybody will be looking at the same thing, so that'll make it less burdensome for the providers. They are also helping us with the financial simulation parts to see if what we come up with as a group is going to work well with provider incentives and with managed care incentives, because we want to be able and this was a point that Secretary Glisson came up with, is we want to be able to see if we can't help with the incentives for the providers by, getting it more funneled with the MACRA and to where we're really helping them do the right choices but still giving us our measure sets as well. This should be lasting for about 12 months, and not the next contract for the managed care organizations, but the one after. We should have a new program in place. The other thing that we are doing, as Secretary Glisson had mentioned, we're trying to take this statewide. And I cannot thank the Kentuckiana Collaborative Organization enough for actually getting with us, setting up a meeting to where we could discuss this, because they're very passionate about working with it, as we are too, to make this a statewide effort. And they have brought together an extreme group of people that includes large employers, commercial insurers, ourselves, and even physicians from around the state, and KMA and KPCA, all of us working together to say, okay, what do physicians feel are important? Because we know we are leading the highest rates of tobacco, obesity, cardiovascular incidences, and also diabetes, deaths from overdoses. So knowing that these are the things that we are the worst in, what measures can we focus on to actually drive and move that needle by working not just as Medicaid, not just as Medicare, but as insurers and payers all across the state, along with physicians, to actually get, if we can improve just a little bit on our diabetic measures and on our tobacco measures, then how much are we going to save in the long run and see healthier people at the other end? Because they're not developing COPD. They're not, having extra weight and having the diabetic issues that they have, or having heart attacks. We're going to see a better, healthier population. That we're meeting for the next 12 months. We've got subcommittee groups that are going to be out there that are going to be selecting a common set of measures that we want to focus on. Once we can all accept that, yes, these are the measures we want to pursue, then we're going to commit to focusing on them. And then we're going to try to talk to all the other providers and the insurers to get them bought on board to make it a unified statewide measure set. Another thing that we're looking at, that I'm working with Lindy Lady on, is trying to see how we can use CPT2 codes to collect some of that quality data that's more on the clinical side, instead of having to do chart pools, because we know chart pools and audits are very cumbersome to the providers and to your offices and your administrative staff. So we're exploring those areas as well. And we're hoping within the next 12 months we will be able to go somewhere that's going to not only benefit our members, but will ease the provider offices' burden and all of the managers that are here that have staff that spend hours and hours and hours on this each week, that hopefully it'll make your job just a little bit easier as well. Now, we do have a little bit of time for question and answers. If you want to provide any questions, please step up to the mic in the middle, give us your name and the organization you're with, and we'll do our best to answer your questions. These are additional resources that you can use to find out more in-depth information on MACRA or any of the quality measures. We also have our email addresses at the end of the presentation, and anybody that would like to get a copy of these emailed to them electronically or the CROSSWALK, we will have sign-up sheets, and you can see us during lunch and give us your name and email, and we'll be glad to send those to you when we get back to the office. And thank you for letting us present. Anybody got any questions? No one. We did such a good job that everybody is either asleep or they just understand it so well no one has a question.
Judy, I've got to ask a question. One of the features of this is obviously to provide some incentive payments to providers who achieve quality scores. Where is that money coming from for the Medicaid program, and do you have those parameters even been kind of established yet in terms of how much?
I have not even begun to scratch the surface on that part of it. I know that currently some of our MCO plans, not all of them, but some of them do offer incentives on their quality measures that they are collecting. So we are actually working with our MCOs to see how we could take that and do it across all MCOs. Plus, we're working with the IAP team to find out I'm not a financial analyst, so I don't do any of those number crunchings, but they're going to help us with the number crunchings and see, what's feasible and how can we do that. And then whatever we come up as a plan with them, we will present to the MCOs, try to get them on board, and try to make this happen. But it's in its infancy.
Just one more question. What about those specialties that today may not necessarily be participating with Medicare, and specifically I'm thinking of pediatric practices? How will they be able to?
Well, the good thing about ours is the things that we are doing with our quality is not just for Medicare doctors. Because in all honesty, we have some that have dual eligibles, but we realize that a lot of them are Medicare providers, not just Medicaid. But our quality program we're developing will be for all Medicaid providers, and it just so happens that they also are included in MACRA. So if you are a physician that are doing Medicare, good for you. But if you don't do Medicare, you're still able to participate in our programs.
Thank you.
Thank you.
I have a question so much as a comment. So we're a private internal medicine practice,
Who are you with?
Central Internal Medicine, Lexington. And our administrative burden from the quality reporting comes from all the different payers want something different, which is what you said. But you said an answer to chart pulls is CPT-2 codes. But those come with their own administrative burden. So if we're going to report on controlling high blood pressure, we have this problem with Anthem right now. So they say, okay, so we need your blood pressures. You can send us a flat file, which we haven't even investigated how the heck to do that. Or you can send us your CPT-2 codes, and we'd like you to go back historically and send in corrected claims for these patients as well. So then I'm not only involving clinical staff person, what is Mrs. Jones' blood pressure, and then a front office person has to be involved, so they have to figure out, this blood pressure corresponds to this CPT-2 code. Then it has to go through claims and billing. Why don't we have can we not use some kind of central system like KHI to deposit these numbers so that we don't have to submit codes and do chart pulls?
Well,
I think CPT-2 code has its own administrative burden as well as the chart pulls and the file transfer. And that's all I have to say.
Now, to address that, actually, you're stealing thunder from another endeavor. There are talks in process that are working with KHI to be able to do more than what it's currently doing. I cannot speak intelligently to how far that endeavor is, but I do know that that has been broached not only by us, but by Lindy Ladies Group as well, and by the KPCA, that we need the clinical data, but there's got to be a warehouse for it. There's got to be a way of getting it in and then being able to run it to report it for somebody else. And there's several of the organizations are working on trying to do that. But again, I'm not leading any of that effort. I am participating in it because we would love to see that happen, to where we could one day say there's no chart pools required. But that's with another group, and I can't really speak to how far they are in that area. But it is being worked on.
She's correct. We are. Some of the things I'm still working with on this initiative are working with us on that initiative. It seems like a logical thing that we're going to have to combine. We need to be able to do lots of impact more effectively. So you're exactly right. And we are exploring that and looking into that. We need to do more work. Thank you.
Mine's more of a comment too. So I'm Dan Cole, I'm president of the Kentucky MGMA for 24 more hours, and then Gina takes over. But I just want to thank you all for coming. We're all here to improve health, and we need to work together. KMA, the Hospital Association, as well as your groups, and all of us working together and supporting each other, because I think in different parts of the state, the practices are not as equipped with the things that they need to be successful. And I think we all have to work together, including big systems like myself in St. Elizabeth in Northern Kentucky. We need to help everybody get better, because we're not doing a good enough job for our citizens. And so we need to work collaboratively. So thank you for trying this. We appreciate it very much.
We appreciate you hosting us and letting us get this message out, and would be glad to work with you more collaboratively in the future. One thing that we are definitely wanting to do is have healthier people. And the first thing that I noticed when I was brought with this problem is Secretary Glisson say, I'm getting a lot of concern from the providers over the burdens that they're facing. Well, I didn't understand what burdens they're facing. I've never worked in a medical office with an electronic health record. I've never had to do the chart pools. I know what quality measures we report, and I know what's required to get those quality measures. So she gave me the permission to go out and start interviewing some of our provider offices. And QSource helped me get in touch with providers that were willing to loan me their managers for the day to go down and actually get in the trenches and say, okay, you've got burdens, but detail them to me. Tell me what it is, because the first thing I do not want to do is start working on this and make it worse. Because if not finding out what the problem actually is, you can, we're going to do this and it's going to be great, and it'd be 10 times worse. Because like you said, with the CPT2 codes, that's a whole nother set. So we are actually trying to keep some focus groups together to keep working on this problem to, if you do the job every day, what is your ideas on fixing some of the problems? Do you have a better way? Be glad to talk to anyone about those, because the more brains you have working on it, the better off you are. So anybody that wants my information, be glad to give it to you, and be glad to talk to you about any ideas that you have. Anybody else? Well, we want to thank you again. I thank Mary Dale for helping me out. I'm a horrible public speaker, and so she took the pressure off of me quite a bit. And thank you all for coming and again allowing us to present to you. It's been a pleasure, and we hope that we can work together more in the future. Thank you.